Today we have a topic that is so cutting edge that it requires input from two of the specialties. Today we have Dr. Jonathan Burns from the Department of Emergency Medicine. He's a board certified in emergency medicine, and also from the Department of Hematology and Oncology, Dr. Joe Merchant, who is board certified in hematology and oncology. And as you can see, they're here to discuss bleeding emergencies and safety issues of new anticoagulants. And I guess Dr. Burns will be starting. So please join me in welcoming Drs. Burns and Merchant.
I get to start. Am I okay volume-wise? This is my first time with the Britney Spears mic, so if it falls off, let me know. So Joe and I have actually wanted to do a talk like this for the last 6 months. Warfarin has been around for over 60 years now, and it's one of the more commonly prescribed medications. It's a medication that all of us in this room have had to deal with in one way or another. In the last 5 years, there has been more changes to the treatment of oral anticoagulation and also reversal in bleeding emergencies than there has been in the 55 years preceding that. And there's so much going on right now that we really wanted to sit and talk a little bit about what's going on, because it's really confusing. You can see I even tried to ask Siri a little bit about bleeding emergencies, and I wasn't really satisfied with the answer I got there. So what we're going to talk about today is benefits and dangers of anticoagulation. We're going to talk about bleeding emergencies. We're going to talk about reversal, as well as some new reversal strategies that are recent. And then I'm going to have Joe talk a little bit more about the new and novel anticoagulants, as well as the appropriate use and some of the risks and precautions that we need to have with those as well. So right off the bat, we have no disclosures. There's no financial interest. We haven't talked to any pharmaceutical representatives or anything with this. In terms of these medications, we'll be talking a lot about drugs by name because these are newer medications and they tend to be isolated medications. I've purposely tried to stray away from industry-sponsored research, but there is a lot of really good evidence-based medicine. There's a lot of really good high-level evidence out there that we can still talk about today with some of these new medications. So no talk about anticoagulation would be complete without this slide. And I'm just going to leave it there. If there's a box in your evaluation that says, did they show the coagulation cascade and did he say we should all remember it from medical school, you can just mark that yes and we'll just go on. The one thing I would only bring up is when we look at this here, I think it's important to note that our vitamin K dependent factors 2, 7, 9, and 10 do lay upstream from the factors that our newer and novel anticoagulants act on, thrombin and 10A, which is important when we talk about the ability, or actually the inability, of how we can reverse some of these newer medications. Now we'll talk a little bit about warfarin. Like I said, warfarin was FDA approved in 1964. It was synthesized from coumarin by physicians from the University of Wisconsin. That WARF is actually an acronym for the Wisconsin Alumni Research Foundation. Since then, it's become one of the more commonly prescribed medications out there. About 1% of our total population is anticoagulated on a vitamin K antagonist. And that number approaches 10% as our patients get above the age of 80. We know it's beneficial in the treatment of non-valvular AFib. We know that it's been well studied in the treatment and prevention of venous thromboembolic disease as well. There's also problems with this, and we all know this well. There's been a couple of good meta-analyses looking at over 13,000 patients that have found that major bleeding events, those are those that require hospitalization, or occur at a risk of about 7.2 per 100 patient years of patients that are anticoagulated, and lethal or fatal bleeding events occur at about 1.3 per 100 patient years of these anticoagulated patients, or about 26,000 annual hospitalizations associated with warfarin and vitamin K antagonist-related emergencies. It is right now the third most common adverse drug reaction associated with hospitalization. That follows after the class of nonsteroidals and the class of diuretics. In addition to that, we also have problems with monitoring. About 50% of our patients at any one time, according to another good meta-analysis, are outside of our therapeutic window. They're either too high, meaning they have a risk of bleeding, are too low and they have an increase of thrombosis. And it goes without saying there's a tremendous amount of drug and food interactions, individual variations, alcohol and disease states can all change this and alter this very narrow therapeutic window that our patients are on. And of course, we need to talk about bleeding. There's spontaneous bleeding emergencies, and what we'll focus on a little bit more today are those traumatic bleeding emergencies as well. In terms of minor events, things like nosebleeds, hemarthrosis, and stable GI bleeds are often well managed with just symptomatic care and cessation of warfarin for a brief period of time. Risk of warfarin skin necrosis, which is much more rare now with better treatment options, is still a very dangerous and still well-recognized risk factor as well. Now, in terms of trauma, I'd like to focus on just head trauma in the anticoagulated patient, particularly a couple of studies that came out just a couple of years ago. It looked about a total of 1,500 patients. We know that intracranial hemorrhage is a real entity when we have anticoagulated patients. 2 studies that looked at these patients. In patients that were CT'd in the emergency department who were anticoagulated, there was an immediate intracranial hemorrhage risk of about 10 to 15% on those patients. There was a delayed risk, meaning patients that initially had a CT that was negative and had follow-up CTs at 24 hours of about 2 to 6%. One of those patients actually having a delayed bleed out to 8 days. We know that as the age increases, as our INR goes above 3, and as we have associated comorbidities like renal failure, cancer, and polypharmacy, that these all increase our risk of acute and delayed bleeding. Now, we do have reversal options, and that's what I want to talk about today. We can always use time as a reversal option. The half-life of warfarin is factor and patient dependent, so there's no real specific half-life we can refer to. It's roughly about 24 hours, so if we look through about 3 half-lives, most patients will normalize out in about 3 days with just cessation of Coumadin alone. We also have factor replacement, and of course that means vitamin K. Vitamin K is dose dependent. The PO route being a little bit slower than the IV route. The subcutaneous route is really no longer recommended because the bioavailability of that is very variable. And of course, we have dilute factor replacement, such as fresh frozen plasma. And given a dose of about 15 milliliters per kilogram, we usually have reversal in about 4 to 6 hours in most of the studies that are out there. But that's also patient and INR dependent as well. What we'll spend a little bit of time talking about today is PCCs, or prothrombin complex concentrates. We'll come back to that in just a little bit. Has anybody heard of or used any PCCs or anything like that in the past here? Okay, so we'll talk about this in a little bit and how this is a new option available to us. Now, the ACCP guidelines for bleeding, which is sort of our current standard, or the sort of chest guidelines that we all refer to reversal, give us a pretty good backbone is what to refer to, and these have recently been updated, and I think they're beneficial to talk a little bit about. If we have a patient who has no clinically significant bleeding, who has an INR that's still less than 5, we can go ahead and hold that dorsal warfarin for a couple days, restart that when that INR approaches more of a therapeutic range. Now, if our INR gets between 5 and 9 on our patient, and there's still no clinically significant risk of bleeding, we can still omit warfarin. We can let that fall on its own. If they do have a bleeding risk, if they are a fall risk, we can go ahead and initiate oral vitamin K at either 1 milligram or 2.5 milligrams. If we need to do that more rapidly, if they have a dental procedure, if they have surgery pending, we can give 2 to 5 milligrams of oral vitamin K with an expected reduction of the INR within about 24 hours. If the INR gets really high, above 9, but we haven't had any clinically significant bleeding at this point, we can give oral vitamin K 3 to 5 milligrams and expect that INR to fall within 24 hours, just rechecking that to make sure that's come down appropriately. Now, that's in the stable patient. If the critically ill bleeding patient comes in with an elevated INR, those guidelines have changed, and this has been a big change in the chest guidelines with the newest 9th edition guidelines that have come out. When we have more rapid reversal needed because we have serious bleeding, major warfarin overdose, then they recommend vitamin K IV. Now, when we give IV, we want to give that slowly. As we give that 10 milligrams IV slowly, that decreases the risk of an adverse drug reaction with the vitamin K and decreases that risk of anaphylaxis. And they recommend supplementing that at that point with either fresh frozen plasma or prothrombin complex concentrates. Now, in the really critically ill, life-threatening bleeding patient with an elevated INR, In a trauma patient or in patients with a serious warfarin overdose, their recommendations are now to give still vitamin K 10 milligrams IV with the administration of prothrombin complex concentrates. And this is a new change to bump this up in the chest guidelines a little bit. That can be repeated in 24 hours, although most studies have shown that one dose is usually pretty good. It's important to know that when we give that much IV vitamin K, we're going to have a hard time getting them back therapeutic again on their INR if that's desired for about a week afterwards. So let's talk a little bit more about PCCs. So prothrombin complex concentrates are just that. They are concentrated factor replacement of our vitamin K-dependent factors 2, 7, 9, and 10. Until last year, our only available option was the off-label use of a 3-factor PCC called Profile 9, which was factors 2, 9, and 10. As of April of last year, the FDA has approved in the United States a medication called Kcentra, which we now have available at Mary Greeley Medical Center. This is a 4-factor PCC that is currently our only medication we have, and is the one, as mentioned above, is recommended by the chest guidelines. Interestingly enough, for those who are using Novo 7, that's now fallen out of the guidelines. So why do we like 4-factor PCCs here in the emergency department? These are used for urgent reversal of the patient with major bleeding. That is their indication. And there are some really good advantages to the use of this over 4-factor PCCs. This is concentrated factor replacement versus dilute factor replacement that we would see in FFP. It's been well studied in Europe. This is a new medication for us in the United States, but it's been available in Europe for 10 and some places in Australia 15 years. And it's been sold under the name of Beriplex or Octaplex there. So although this is FDA approved here, it's been heavily used in Europe under those brand names as well. It's the same medication. The big advantage of this is that it's small volume replacement, which is key. So there's no risk of transfusion-associated circulatory overload, and that's a big deal in a lot of our anticoagulated patients who are already volume overloaded, who may have a poor EF, who may have associated renal function, and can't tolerate that liter to liter and a half of FFP that they may need at a fairly fast rate to normalize their INR. This is given at a dose of about 40 to 80 mils. There's no thawing that's needed with this medication. It's a reconstituted medication. It's reconstituted in pharmacy, and it has rapid reversal. We talked about FFP having a 4 to 6 hour reversal time. This has been well studied to bring patients, even with high INRs, down to an INR of 1.3 or less in under 30 minutes. One dose is needed in only 24 hours, and oftentimes when it's given concomitantly with vitamin K, that's all we need. And there's a more favorable adverse effect profile than with the administration of FFP. There's no risk of any transfusion-related lung injury. There's minimal risk of transfusion reactions. And one nice study that actually took a look at this as an independent variable, they actually found that in patients that were randomized to FFP versus PCC, the patients that got FFP required twice as much PRBCs, or twice as much blood replacement, as those who got the prothrombin complex concentrates. We like this in the ER too because of our regional setting. If we have patients who come in with a critically ill bleed, an intracranial hemorrhage, and we don't have neurosurgical capabilities currently right now, we need to get those patients to a higher level of care as quickly as possible. And the ability to give a medication like this and get them to that higher level of care either in Iowa City or Des Moines rapidly is advantageous for us rather than waiting for the 20 to 30 minutes that it takes to thaw, as well as also time associated with cross-match. So it's very beneficial for us in our setting here in Mary Greeley in the ER as well. Now there's some disadvantages as well. There's a theoretical increase in thrombosis. This has been shown in some of the European studies. This has not really been well parsed out. Unfortunately, our patients that are anticoagulated have a tendency to be a little bit thrombogenic to begin with. And so patients that are reversed rapidly do have a risk of developing thrombosis, whether or not that's their own pathology and their own chemistry or a side effect of the medication is not well understood yet, but it's probably something to be aware of. And then, of course, cost. Right now at Mary Greeley Medical Center, our cost to patient for 4-factor PCC is about $1.27 per unit, and we're giving this in sometimes between about 1,525 units per patient. That goes for our cost to patients for FFP of about $125 for a bag of FFP. And finally, it's worthwhile to talk about mortality outcomes. When we look at our disease-associated outcomes, such as the need to transfuse blood, we find that's much less. And when we find the decrease in INR, we find that we do much better with that. When we find the volume of intracranial hemorrhage is much less with patients who receive PCC versus FFP. When we look at our overall patient outcomes, though, our mortality really doesn't change between FFP and PCC groups. And that may just go to show, at least with the intracranial hemorrhage, that any day you're bleeding in your brain is going to be a bad day. But unfortunately, we can't really say that PCCs are better at this point, just that they show some non-inferiority. But I think over time, this will parse out a little bit to show that this may be a more advantageous medication. So it is dosed, and this, by the way, is I'm being told being built by the Willow team into Epic as we speak, hopefully this week. So the dosage is based both on pre-existing INR as well as the patient's weight. So it's given an INR 2 to 4, 4 to 6, or greater than 6, and it's dosed by units of factor 9 present, so either 25, 35, or 50 with the max dose that's listed below. So an 80 kilogram patient with an INR of 5 that needed rapid reversal would get 80 times 35 or 2,800 units of Kcentra as a one-time dose. So a little bit more, I think it's important to state that this is right now indicated only for acute major bleeding or the need for urgent surgery or an invasive procedure only. This is not a medication that you're going to give to your patients who have a supratherapeutic INR and have some bleeding gums. Right now it's only for that acute or major bleeding only. When they did look at healthy volunteers with INRs, laboratory INRs up to 60, they were still able to get an INR of 1.3 or less in 30 minutes after the initiation or start of the administration of the drug. However, it's still recommended that INR be rechecked 30 minutes after administration. It is contraindicated in patients with HIT. There is a small amount of heparin in the drug, DIC or known anaphylaxis. And it was not studied as the exclusion criteria for most of the major trials. Any patient with a thrombotic event in the last 3 months was immediately excluded. So we don't know really what it's going to do in patients who've had a thrombotic event in the last 90 days. So just caution is advised at that point. So what about PCCs and the new anticoagulants? Joe is going to talk here a little bit about some of these newer medications, dabigatran, rivaroxaban, and apixaban, which are our newer medications, Pradaxa being the direct thrombin inhibitor, the other two acting on factor 10A. And it's important to know with these new medications, there is no antidote and there's no specific reversal agent. FFP does not work for these. There's recommendations all over the board to try factor VIII inhibiting bypass agent, PCCs, Novo-7, and dialysis with really no good outcomes with anything other than maybe dialysis. There was one study out of Circulation in 2011 that tried four-factor PCC versus reversal of Pradaxa and rivaroxaban, which is a Xarelto, in these patients, and found that they were able in the laboratory to effectively reverse rivaroxaban, but that's the only study, and it's really not FDA approved for that. For dabigatran or Pradaxa, it does not work. They were able to show that in this study, and really outside of possibly dialysis, there's really no given reversal agent for these new medications. And Joe's going to come up here right now and he's going to talk a little bit about that. I know that's really confusing. I got confused enough to want to jump off a bridge, but Siri didn't help me much with that as well.
Does this look right? Can people hear me okay? Just a little bit. Okay. Well, I appreciate you all being here, and I want to salute Dr. Burns for bringing this topic forward. He contacted our department when he was seeking support for getting Kcentra on our formulary, and I think it's to his credit that we're here today. These new anticoagulants bring a whole different group of concerns to us as hematologists, but really all of us, especially the emergency room, is on the front lines and taking care of patients on these new medications. So I wanted to start with the case presentation. This is from an article that was published, so this is a real case that brings out some of the concerns with dabigatran. This is a 79-year-old man who was sent for aortic valve replacement. The patient had, as many of our patients do have, other comorbidities, including type 2 diabetes. He had some mild renal insufficiency, and of course his severe aortic stenosis. As per the recommendations on the package insert, the medication was stopped 2 days prior to surgery, and his surgery was performed. This is an open heart procedure with standard heparin anticoagulation and protamine reversal. He had severe bleeding at the time of his operation, 1,500 mLs per hour, which was not responsive to all of the standard maneuvers that they are used to using in the OR, including protamine, cryoprecipitate, FFP, platelets, tranexamic acid, and he continued to bleed at a very high rate. They were unable to close the sternum. The patient was given 2 doses of Novo-7, activated factor 7A, actually 3 doses without control. And then he got 2 more higher doses of activated 7A, a very expensive medication, by the way, and that reduced his bleeding down to only 800 mLs per hour. He was able to be sent from the OR to the ICU, and hemodialysis was started, which was able to reduce his bleeding further. They were able to measure a dabigatran level and report it later, and immediately prior to dialysis, his level was 76, which is a little lower than the therapeutic level, and it went down to 27 after dialysis. This is it's kind of a busy slide, but it shows these are all the things this man got. Look at how many units of blood he got. Look at all the platelets, all the plasma. I mean, this is like, 20 units of plasma, a bunch of cryoprecipitate. And this down below is the amount of bleeding he had. So these new drugs are no joke. They cause real bleeding and real problems in relation to surgery. So there are, and also I think this demonstrates pretty clearly, there really isn't an antidote for dabigatran. I mean, nothing FFP 20 units doesn't fix this bleeding. So it's not something that we can sort of shrug off and say, oh, we'll worry about it later. This is something Dr. Burns has seen already in the emergency room, and all across the country there are problems. So I want to talk briefly about the nature of these new drugs, one of which is, the first one I'll talk about is Pradaxa or dabigatran. This is a thrombin inhibitor. It works very quickly. One of the advantages of these new drugs is they work very quickly. So it peaks in the serum plasma 2 hours after administration. Its half-life is about 14 hours to 17 hours. Its oral bioavailability is 6%. It's combined in the pill. It's combined with tartaric acid, which will help its absorption. But some people feel that the tartaric acid can cause some of the indigestion and dyspepsia that patients on this medication have. This medication is not dependent on oral acidity, so you can take it with PPIs or omeprazole, etc. And this medication has to be taken intact. It can't be used through a GI tube or NG tube. It can't be broken and given that way. 80% of the absorbed drug is excreted unchanged in the kidney. It's a substrate of P-glycoprotein, so medications that inhibit or affect the P-glycoprotein will affect the levels, including quinidine, amiodarone, verapamil, ketoconazole. Dyspepsia is about 10%, and that's because of probably the tartaric acid. The medication, because only 6% is bioavailable, a fair amount of dabigatran gets into the lower GI tract, and that's why, it's at least one reason is speculated why, that these new novel anticoagulants cause a little bit more lower GI bleeding than Coumadin does. The idea being that the medicine is there in the rectum, causing some local anticoagulation. This appears to be most relevant in people who are over the age of 85. They're currently approved in the U.S. for prevention of venous thrombosis after orthopedic surgery, hip and knee replacement, and then also atrial fibrillation. Rivaroxaban or Xarelto and also apixaban, which I'll talk about next, are factor 10A inhibitors. So the one we just talked about, thrombin inhibitor, now this is a factor 10A inhibitor. This medication also works very quickly. Its half-life is about 5 to 9 hours. Can be longer, though, in patients who are older. Food does not affect the absorption. The oral bioavailability is quite a bit higher than Pradaxa. It's best absorbed in the stomach. It may be crushed and administered through a G-tube or NG tube. This medication has a dual mode of elimination, with 1/3 excreted in the kidneys and the 2/3 by the liver. There are some important drug interactions to keep in mind. Medicines that affect the CYP3A4 enzymes, cytochrome enzymes are listed here. Shouldn't be used in patients with child's class B or C liver disease because of its dual mode of elimination, and it's contraindicated in patients with a creatinine clearance less than 30. Apixaban is another factor 10A inhibitor. This medication has a little less oral bioavailability, 50%. It also peaks very quickly. It's absorbed throughout the GI tract, as a little distinguished from rivaroxaban. It's also metabolized by the CYP3A4 enzymes in the liver, and that levels, also inhibitors of P-glycoprotein can raise the levels, and a lower dose is suggested. Again, patients with moderate to severe liver disease shouldn't use this medication. And there's just a table here that outlines, you have a little more, I think a little bit more forgiveness with renal insufficiency with this drug, although it's still recommended to be used only with caution with lower creatinine clearance, less than 15 to 29. Now, I'm not going to go into all the indications and all the research that's being done to look at what indications these drugs should be used for, but I do want to focus mostly today on atrial fibrillation. This is a graph that demonstrates the expected rising incidence of atrial fibrillation over the coming decades. Here's out to 2050. We're going to have a lot of patients with atrial fibrillation to take care of. And so the medications that we're talking about for prevention of stroke and atrial fibrillation are going to be important for our future practices. I'm going to focus real briefly here on 3 trials. The first is the RELY trial, which looks at Pradaxa or dabigatran in atrial fibrillation. The second is the ROCKET-AF trial, and the third is the Aristotle trial. And those two look at rivaroxaban and apixaban respectively. These are big trials, well-conducted trials. Look at how many patients, 18,000, 14,000, 18,000. Focus on the median age here, roughly 70 years old. I'll tell you that the average weight of patients in these trials is about 80 kilograms. You can see that the majority are male, and then you can look at, if you like, the efficacy, which demonstrates that there is an advantage to the new drugs compared to warfarin. If you look for dabigatran, the risk. Oops. Can you still hear me? Okay, good. So if you look at Pradaxa, the risk with the therapeutic dose of 150 milligrams, you have a 1.1% risk per year of stroke compared to 1.7% per year with warfarin. This is statistically significant. With rivaroxaban, the risk is reduced from 2.4 down to 2.1%. This is considered to be statistically equivalent, which allowed it to be approved for this use. And then for apixaban, the risk is down from 1.6 to 1.2, and that is considered statistically significant. The bleeding risk is actually higher in these trials with warfarin, generally speaking, than with the newer drugs. And that's important because if you look here, warfarin, 3.36% per year versus 3.1. Here it's 3.45 versus 3.6, so that's the same. And here it's 3.09 versus 2.4. That's considered an advantage potentially for the newer drugs, that they may seem to be both more effective and less bleeding. However, if you read the papers closely, it's clear that the patients who were on warfarin had I guess you would say, average experience as far as how often they were in the therapeutic range. They had about 60% of the time where their prothrombin time was measured, they were therapeutic. That is actually, if you look at this and reading some papers, that's about what we do in clinical practice. If you measure, if you have a person on Coumadin, you can tell them, well, about 60% of the time, we're going to have you in the therapeutic range. There's going to be, sometimes you're going to be above, sometimes you're going to be below. So what some smart researchers have done is they've gone back and they've analyzed these trials based on the percentage of time the patients were in the therapeutic range. This is with the RELY trial, and as you can see, if you get down to the bottom, if your patient is in the therapeutic range more than 72% of the time, then there's no real difference in the stroke risk, or really even in the bleeding risk, between warfarin and Pradaxa. Similarly, they've done the same reanalysis of the ROCKET-AF trial and demonstrated that the ratio, or at least the difference between the two, is narrowed when you achieve better control of the warfarin. Dr. Burns has talked a lot about warfarin, and I don't want to talk too much, but I do want to just mention, because I'm going to be talking about some of the disadvantages of the new drugs. Warfarin is a drug that we all know has a lot of disadvantages. There's a lot of individual variation based on a lot of things like diet, alcohol, medications. You have to go in and have your INR regularly checked, or else you have to have a home device to do it. And there is a higher risk with warfarin of intracranial bleeding, which Dr. Burns talked about as being a big concern in the emergency department. Warfarin does, however, prevent about 60% of strokes in atrial fibrillation, and there's a lot of concern that it's being underutilized in elderly people because physicians have worries about frailty and bleeding risk, etc. So only 50% of patients with atrial fibrillation take the drug. If you're on the drug for atrial fibrillation, only about half of the patients are well controlled, meaning that their time in therapeutic range is more than 65%. So some of these other points have been made by Dr. Burns. I just want to say that we physicians think we do a great job, but we really statistically do an inferior job compared to Prothrombin Clinic, et cetera. Those clinics have been demonstrated to do a lot better job in managing and keeping our patients in the therapeutic range. Warfarin in the extreme elderly, I just wanted to bring one trial here. This is a trial from Italy involving 4,000 patients, all over the age of 80 when they were started on warfarin. And the incidence of major bleeding in these patients was 1.87 per 100 patient years. These patients were all well controlled, with 62% of the time being in therapeutic range. The risk of bleeding was highest in the first 3 months. So it's important when you're starting a patient on warfarin, that first 3 months is really critical. 82% of the bleeds occur in patients who are in the therapeutic range. So it's not just the patients who have an INR of 10 that are bleeding. In fact, the majority, 80%, were in the therapeutic range. 30% are intracranial, 14% are fatal. And there are some risk factors for bleeding that are listed there, age greater than 85 being one of them. Also, just as a comparison to the newer drugs, people say, well, you know, the newer drugs, you don't have to be monitored, that's an advantage. But some of our patients on warfarin are extremely easy to control on warfarin. And there have been studies demonstrating that it is safe to spread out the visits for INR checks in those very stable patients to 3 months, which makes it a little less unequal in terms of the hassle factor comparing warfarin to some of the newer anticoagulants. These are in the time I have remaining, some of the safety issues I want to touch on about the new anticoagulants. First, I want to talk about overdose and bleeding, some about laboratory monitoring, peri-procedural management, conversions from the novel anticoagulants to warfarin and vice versa, and also concomitant use of antiplatelet agents and some important drug interactions, which I've really already talked about a little bit. So when I talk about this, I'll try to separate the different drugs, different classes of drugs anyway. With dabigatran, my first slide, the case study showed there really is no antidote for dabigatran. If a patient takes an intentional overdose, you can, and you catch it soon enough, it is recommended to try gastric lavage and charcoal. However, FFP and PCCs do not reverse the effect of these drugs. Recombinant factor 7A has been demonstrated to, in limited few patients, to slightly lower the rate of bleeding, but it doesn't stop bleeding or reverse anticoagulation. Hemodialysis may be effective, but it's a challenge to put a big dialysis line in and organize dialysis in the emergency department or in the OR. So it's not a great situation to have severe bleeding while you're on dabigatran. If you have rivaroxaban and apixaban on board, however, these are reversible by PCCs, we think, and also they are not dialyzable because they are they're just not dialyzable. Dr. Burns demonstrated or gave you a table about the dose of PCC to be used in a patient on Coumadin. If you have to use a PCC for a patient on these two drugs, it's suggested that you use the highest dose, that is 50 units per kilogram, directly to fully inhibit the anticoagulant effect. This is just a schematic about stuff that we all know that we have to do in a bleeding patient. A lot of this is ABCs of regular supportive care. With dabigatran, they want you to keep the patient urinating because it's obviously excreted through the kidneys. Consider hemodialysis. With the others, PCCs are suggested. Probably will not work for dabigatran though. This is a brief schematic about a study done with patients on dabigatran who were hemodialyzed, and you can see that the dialysis has to be done more than once to really get the level down effectively. Laboratory monitoring, the thrombin time is a useful test for dabigatran in that if it's normal, the dabigatran is gone from the system or effectively not there. However, it's not, if it's elevated, it doesn't track linearly with the dose or the degree of anticoagulation. So it's not a useful test in monitoring patients, and an elevated level doesn't imply overdose. The protime is not sensitive to dabigatran. It's not useful to judge drug effect. The PTT, however, does have a curvilinear response to dabigatran. And if you have a very, very high PTT, then that probably would be compatible with some degree of overdose. In interpreting the PTT, you have to take into account exactly when the patient took their medication. Also, the last thing on this slide is that the eccrine clotting time, or ECT, may be the best test for measurement of Pradaxa or dabigatran effect, but it's not FDA approved, and we don't have it available here. Probably some version of it will be FDA approved. With regard to the rivaroxaban, it can be checked with the protime. However, the different thromboplastins have to, similarly with warfarin, where we use the international normalized ratio, there's an effort underway to standardize the thromboplastins for the measurement of rivaroxaban effect. And eventually, we probably will have an INR type situation where a person can have their rivaroxaban checked in Ames or in Florida or in Arizona and know that they're in the therapeutic range. We're also, anti-factor 10A levels can be used, but that has to be worked on further. It's not currently FDA approved, and apixaban can't be measured with the protime. It doesn't prolong the protime. Periprocedural management. This is where the first patient got into trouble. The patient, there are guidelines about when you should stop these drugs prior to procedures. If you're doing a relatively minor procedure, like cardiac cath or diagnostic endoscopy, you should stop 24 hours prior, 2 doses prior. However, any surgery with a higher risk of bleeding should be at least 48 hours. And this is a table talking about timing of last dose prior to surgery. And I would just point out that, if you have if you have low kidney function, you're talking about stopping 6 days prior to surgery for dabigatran and 4 days for rivaroxaban. When you're converting a novel anticoagulant to warfarin, there are some guidelines here that talk about the number of days you need in advance, and you have to pay close attention to the kidney function. And we're getting close on time, so I'm going to kind of hurry up. But this also, when you're converting from warfarin to the new anticoagulants, the key point is that you've got to stop the warfarin. You don't overlap the drugs, and you don't start the new drugs until the INR is less than 2.3. Concomitant use with antiplatelet agents. This is not considered safe based on trials that were done in the acute coronary syndrome setting. The PRAISE trial is one that I brought here, and if you look at the apixaban 10 milligram, 2.5 milligram, or placebo, you can see that there's a much higher risk of bleeding. This seems to be especially in patients who are on Plavix and aspirin, as opposed to just aspirin alone. There are a number of drug interactions that I've touched on. It's really important to pay attention to drug interactions with these drugs. And just as a summary, some of the concerns or disadvantages potentially. One is the short half-life. That's a nice thing. It works right away. But also, there have been some evidence that patients who are non-compliant with their medications have a higher risk of stroke. One of the nice things about Coumadin is the long half-life, and if a person misses a dose, they aren't going to be untherapeutic 12 hours later. These new medications are really expensive, and at least in the case of Pradaxa, they're twice daily dosing. And so patients who are inclined to try to make their dollars stretch by taking their medicine once a day instead of twice a day will be spending half the time not anticoagulated at all. There's a potential for increased risk of stroke and systemic embolism when patients don't take their medicine. One of the disadvantages potentially is that they aren't being monitored, and that's a potential lost opportunity to talk to patients about whether they're compliant. There have been a lot of deaths reported from the use of these medications. I handed out a brief thing from Australia and New Zealand where they audited the first several months and found a lot of patients being put on these drugs inappropriately with elevated creatinine and then having bleeding complications. You can't really titrate the dose. There's no way to assess for whether the patient is failing therapy. If they have a stroke, did they fail because they didn't take their medicine? They weren't on enough? It's hard to tell. You can't tell in situations where you need urgent surgery or life-threatening bleeding what the level of the medication is. There's no antidote. There's no well-established procedure for reversing the anticoagulation. And the medicines are expensive. Out-of-pocket expense, $3,000 compared to $50 for Warfarin. This is the medication only, not the monitoring. This cost can affect compliance. So I always have a lot of concern, especially when a patient comes back to me and they've been started on Pradaxa and I didn't know about it and they're 85. So, I just think these medicines, I just want to throw the caution flag up a little bit and say, let's go slow and let's only use these medicines in patients who are fitting the criteria, that is, in their 70s, not in their late 80s, and also in their people with normal weight and normal kidney function. You've got to take caution if they're over the age of 80, or if they weigh 60 kilos or less, little ladies especially, those ladies should not be given therapeutic doses probably, because that's probably an overdose for them. So anyway, I want to thank Dr. Burns again and conclude here. And I know it's late, so I don't know if there's time for questions, but we're both willing to take questions. Any questions? Okay, good. All right, thank you everyone for coming. I put this on backwards when I first put it on.